Contrast media reactions, which is a very important subject to know most of the aspects related to it. We'll start giving you a background about the contrast material. The first introduced iodinated contrast agent was in 1950. The first used gadolinium-based contrast was in 1988. And the terminology of contrast media reaction refers to a group of symptoms and signs with different degree of severity, different type of onset that may occur after the administration of contrast. So we are dealing with different severities and different time of onset. The reaction from contrast media occurs with mostly intravenous or intra-arterial administration and is usually mild and self-limited. This is very important note. The overall estimation of contrast reaction is, it is usually mild and self-limited. Other extravascular routes have minimal chance of occurrence and minimal severity. What we mean by the other routes? Intrathecal, intracavitary, oral, rectal, percutaneous, all these routes, they have improved chance of reaction, but it is, to be honest, is minimal occurrence and minimal severity. This reaction can be considered as allergy-like reaction. It is not pure allergy or hypersensitivity. And the second type of this reaction is called physiologic reaction. Either it is an allergy-like or physiologic in nature. And according to the severity, and according to the types, it is called allergy-like or physiological. According to the severity, it is classified into mild, moderate, and severe, and also can be defined by the time of onset, whether it is acute, when occurring within the first 20 to 30 minutes after injection, or delayed, if it occurs from 30 minutes to 1 week. But it is reported in the literature and in the reality that contrast reaction might be delayed for 1 week after contrast injection. Okay? Let's go through some pathophysiology which is related to the subject. The exact mechanism responsible for adverse reaction to contrast media are till now not entirely understood, but can be broadly divided into, as we mentioned, allergic-like or physiologic. The physiologic is also called chemotoxic reaction. Why we have this terminology allergy-like reaction, not allergy? Because it shows similar signs to allergy, but they are not considered hypersensitivity reactions due to the following causes. The first cause, it is not always IgE involved in this type of reaction. So it doesn't completely mimic the true hypersensitivity of allergy. IgE, which is the main agent responsible for allergy-induced reactions, is sometimes absent in the contrast reactions. Second point, antigen-antibody reaction is not always present in contrast reactions, not like hypersensitivity reactions. The third point, previous sensitization is not required. Having a history of contrast reaction, it means that definitely the next administration will give you similar reaction. This is not reported in contrast reaction. So it is also different from true hypersensitivity or allergy. And the fourth point is this reaction is not necessarily to occur in each patient. So these four items differentiate the contrast reaction from the true allergy or hypersensitivity. So let's agree that we call it allergy-like, but it is not true hypersensitivity or allergy. Okay? The precise pathogenesis now in allergy-like reactions, we are insisting to call it like this, at the cell level is the release of histamine. This is shared with allergy. And the activation of complement system, release of bradykinin, added mechanism of direct effect on cell membrane from osmolality. This is how contrast produces its effect, whether in the allergy-like reactions. It goes through the cell level, production of histamine, activation of complement system, bradykinin, or direct effect on the cell membrane. This is just to know how the contrast produces its reaction. The other type of contrast reaction is called physiologic or chemotoxic reaction, occur primarily due to molecular characteristic and binding characteristics of the contrast itself, and direct activation of complement system and bradykinin, not through histamine. For the difference in physiologic reaction, it is not involving histamine as a precursor for the reaction, and it is not related to activation of the complement system and etc. It is directly related to the characteristic of the molecule in the contrast itself. This is important because you will see now what are the symptoms related to the physiologic and what are the symptoms related to the allergic. You will recognize that the physiologic definitely differ from the allergic type of reactions. Okay? First important subject to deal with when you are concerned about contrast reaction is the risk factors. Who is the patient with risk factor for you? Number one, and the most important, is history of previous reaction to iodinated contrast media. This is the most important risk factor for contrast reaction. Second is atopy disease, which is congenital hypersensitivity or allergy, and the most common is asthma. Asthma is a risk factor for contrast injection. Third is thyroid disorders. Thyroid disorders is proved to be a real risk factor for contrast reaction. The use of contrast should be avoided in patients who are experiencing thyroid storm, receiving iodine therapy, or undergoing reactive imaging. This is our work. Either patient in storm, or he took iodine therapy, or having a plan or appointment for radioactive imaging of the thyroid gland. In these patients who have received iodinated contrast material, the ACR guidelines suggest a washout period before initiation of radioactive iodine therapy or radioactive iodine imaging, about 3 to 4 weeks. Keep this in mind. If the patient is having to go for radioiodine imaging or therapy, you have to postpone appointment or contrast imaging between 2 events, 3 to 4 weeks, to give it a wash of the contrast material. And patient with undertreated Graves' disease or a multinuclear goiter may be also a theoretical risk for thyrotoxicosis. Patients who have Graves' disease also might develop inflammation and acute illness of the thyroid gland. Thus, only patients with normal thyroid function are encouraged to receive isolated contrast material. So thyroid disease is proved by the ACR as a risk factor for contrast injection. And we have to remember this 3 to 4 weeks gap or washout period between the contrast and the radioactive injection. We should not combine it at the same time. Kidney insufficiency is a major risk factor for contrast. Excretion of contrast occurs principally via the kidney. So decreased kidney function has been associated with contrast-associated acute injury or associated injury. And we have 2 types of renal injury in contrast material. We call it acute kidney injury or associated kidney injury. We'll discuss them later if we have time. Sickle cell disease is a risk factor. It can produce sickle crisis in patients who have sickle disease. Phaeochromocytoma can have an attack of hypertension due to the contrast material. Please remember it as a technician. Okay, if the patient has phaeochromocytoma, be aware of the contrast. It might accelerate hypertension in such a patient. Myasthenia gravis and multiple myeloma have direct effect on the kidney. Multiple myeloma patient, they have direct effect on the kidney due to the contrast material. What is the incidence of contrast reactions? Over the 40 to 70 million imaging studies with contrast, only 0.6% of iodinated contrast media reactions, allergy-like reactions, occur, and only 0.01 to 0.2 occur with gadolinium-based contrast material. It is a very low incident. Okay? Rates of severe reactions to iodinated contrast material and gadolinium are estimated at 0.04% for the iodinated contrast and 0.008% for the gadolinium based. Iodinated is 0.04 and 0.008 for the gadolinium based. So we notice from this note that gadolinium is much less to have reaction than iodinated contrast reaction. The severe form of reaction is very minimal in both, and the number incidence of reaction is from the studies with contrast is also too low. The results that have been present in the literature with high values are related to the previous era of iodinated contrast material. The incidence of 5 to 15% in the 1980s, this is when we used osmolar ionic contrast material at that time. When we start to use the non-ionic contrast material, dramatically and markedly reduced chance of contrast reactions definitely occur at all levels. Okay? This was a big solution and era in the contrast subject for reaction and severity. For oral contrast, reaction is about 1 in 75,000. For MRI, the reaction is usually mild and physiologic, not allergic type. Okay? This is the studies and statistics about the incidence of contrast reaction. Time between contrast examination in the same patient. This is also important for the technicians and doctors. 75% of the contrast is excreted within 4 hours. So the guidelines are to suggest waiting at least 4 hours before second intra-iodinated contrast material injection. Okay, memorize this time between contrast. And this also applies if the patient receives iodinated contrast for CD and followed by gadolinium-based for MRI. It happens, the patient goes from the CT to MRI. 4 hours also applied between the iodinated contrast for the CT and giving the contrast of MRI. For renal impairment, 48 hours delay is needed in case of contrast. This is the recommendation by the Urology of European Urology Association. What questions need to ask prior to contrast examination? Most radiology departments have these questions. We'll pass through them quickly. Prior known moderate to severe reaction to contrast is more important than mild. When the patients say that I have rashes or feeling of nausea, vomiting, mild cases, we are not too much concerned about it. Moderate to severe reaction. Kidney disease, including kidney, chronic disease, acute kidney, diabetes, hypertension, proteinuria, nephrectomy or one-side kidney, hyperuricemia or gout, unstable asthma, atopy, non-cardiac disease or heart failure, other medical illnesses, and medication history with metformin. These are the questions that we put already in our preparation for the contrast. Screening for the kidney disease indicated because it is the strongest known predictor of contrast nephropathy if the patient has an element of underlying kidney disease. Regarding the timing of kidney function studies, there is a guideline. American College of Radiology guidelines suggest determining GFR within 7 days prior to contrast injection for whom? For inpatients with an acute illness or patients with acute deterioration of chronic illness or hospitalized patient. This is the time, 7 days. But for outpatients, they have proposed 30 days as accepted test for acceptable time interval for the last kidney evaluation. Okay, inpatient 7 days and outpatient 30 days. There are a lot of misconceptions about contrast material. We'll go through the commonest misconceptions. This is number 1. A previous hypersensitivity reaction to other iodine-containing compounds increases the risk of a contrast media reaction. This is a misconception. The answer? It is a misconception that iodine is the antigenic component. This is very important. The iodine structure in the contrast material is not the cause of allergy. Sometimes we ask the patient, have you allergy for iodine? This is not true. This is not scientific. The allergy in contrast material is not related to the iodine. It is related to chelating agents, other agents present in the contrast. So this is not a good question or a true question, and this is the answer. Allergies to elemental iodine do not exist. It is due to allergy to other chemical molecules. And allergy in the iodine in the salts, allergy in the fish, this doesn't means that the patient has allergy. It is not the responsible subject for allergy, but this is the first misconception. Second, a contrast media reaction will not be seen at first exposure in a patient. This is, it will not happen for the first time, okay, after exposure. You have to be exposure for the contrast. Then in your body, there will be for the next injection a reaction. This is a misconception, okay? It is erroneous to assume that patients who are naive to contrast media cannot have a reaction. Even anaphylaxis has been reported in patients for the first time with no even documented history of contrast reaction. This is why we are talking about this subject. Patient never exposed, no history, no allergy, is coming to the department as candidate for contrast, he might develop anaphylaxis. Scientifically, he might develop it. Okay? Previous sensitization, previous exposure doesn't exclude or the reaction. Third misconception, shellfish allergy increases the risk of contrast media reaction. There is no evidence for that. Okay? Allergy to contrast is dose dependent. It is a misconception. Allergy to contrast is not dose dependent, can occur with minimal amount of contrast. 1 ml can produce severe allergy. Asthma is contraindication for contrast administration. It is a misconception. It is considered just a risk factor and can be managed by premedication. It is not a contraindication. Skin testing is needed prior to contrast administration. It is a misconception. It is not useful in contrast. And American College of Radiology guidelines do not recommend skin testing in patients who have reaction to contrast even. Pregnancy and breastfeeding are contraindication for contrast. It is a misconception. There is no proof evidence of teratogenic effect of contrast. However, iodinated contrast media should be avoided if possible. Only 1% of contrast passes into the breast milk, of which only 1% is absorbed by the GI of the fetus. In some centers, they advise to stop breastfeeding 24 hours post-contrast injection. This is regarding the contrast media. Okay. I think this is related to the MRI contrast. The CT is not indicated to stop the breastfeeding. Okay. 8. Allergy to specific contrast media indicate allergy for all contrast. If you have certain type, you got iomerone, or Omnipaque, whatever. This is also added to the misconception. Changing the type of contrast is one of the preventive recommendations in case of proof allergy. This is written in the ACR guidelines. If the patient has a contrast for ultraviolet, if you change the contrast to another type, most likely it will solve the problem. Because of what I said before, the allergy is due to the structure, compound, molecular, rather than the iodine or other major component. Complications is the subsequent topic about knowing all these informations. Allergy-like reactions. We classify these into two types. You remember physiologic and allergic. These are the commonest mild symptoms of the allergic-like reactions. Focal. Please remember the word focal. Focal urticaria, which is the most commonly reported adverse reaction. Pruritus, focal. Cutaneous edema is focal. Nasal congestion, sneezing, and conjunctivitis. Then what characterized the mild reaction is focal reaction. The patients say, along the site of injection, in my leg, in my thigh, in my face, there is focal changes of pruritus or erythema or edema, and focal in the congestion, sneezing, conjunctivitis. Patients with mild symptoms do not require treatment. Remember yesterday exercise? However, should be observed for progression or evolution of a more severe reaction which requires treatment. It is usually doesn't need either medication or taking any chance of severity. Allergic-like reactions are moderate. Moderate is diffuse, all the body. Diffuse urticaria, pruritus, or edema, but with stable vital signs. If the patient asks for help, I'm having all my body. If the stable vital signs are present, this is moderate reaction. Okay? Facial edema, tightness in the throat, bronchospasm, dyspnea. He's starting to have something in his breathing, either localized in the area of the throat or in the face, or cannot take a breath. But at the same time, he is having normal oxygen. This is okay, moderate. Normal oxygen is moderate, normal vital signs. Remember, the same symptoms before, but with stable vital signs and minimal hypoxia or normal oxygen levels. Okay, this is moderate. Severe form comes to positive changes in the hemodynamics. Diffuse facial edema with dyspnea. Diffuse erythema with decreased blood pressure. Laryngeal edema with stridor. The patient is masking, taking or constricting his okay? And wheezing, bronchospasm with hypoxia or anaphylaxis shock. Okay? What is the definition of anaphylaxis? Anaphylaxis is the most severe form of allergy. It is characterized by systematic involvement, internal organ involvement, cardiopulmonary, respiratory, or kidney. Okay? Okay, this is the definition of allergic anaphylaxis. The word anaphylaxis, you might hear it in the emergency room, or from doctors, physicians, or from textbook when you read it. Anaphylaxis is the severest form of allergy. Okay? It includes hypotension, tachycardia, stridor, or اللي needs مثلا intubation for you as a knowledge, and alteration, arrhythmia, cardiac involvement, يعني kidney, pulmonary edema, cardiac abnormal rhythm, super tachycardia, whatever يعني related to the abnormal rhythm or arrhythmias, and multiple system organs. But it is a fatal condition, but it's not a cardiopulmonary arrest. It is a severe form of organ allergy that initiates hyperactive management, but not a CPR. Okay? But again, severe symptoms should be memorized. Is it diffuse changes, but with parameters: shortness of breath, dyspnea, decreased blood pressure, increased pulse, stridor, hypoxia, decreased oxygen, and anaphylaxis, the multiple organ failure. Physiologic reactions, you will remember now, it is mild cases here, nausea and emesis, vomiting, nausea. Nausea and vomiting is a physiologic reaction. Urticaria and pleuritis and erythema is allergy-like reaction. Okay? Headache, it is symptomatic. Dizziness and anxiety, increased blood sugar, and vasovagal reaction. Remember these symptoms because they are organic symptoms. The patient is physically having problem. He wants to nauseate, vomit, headache, seizure, hypertension. These are physiologic reactions, and we, to be honest, we experience, I think, high percent of our patients' reactions goes into this category. I feel hotness, I feel thermal. These are physiologic reactions. These are not through histamine, not allergy. These are due to organ direct effect. Okay, toxicity to a certain level on the organ. Okay, which produces headache, dizziness, or vasovagal attack. Moderate symptoms, prolonged nausea or vomiting. Hona, regarding the allergic type, focal and diffuse. For the moderate, in case of physiologic, it is not just a temporary nausea and vomiting, prolonged, exaggerated, okay? More case of nausea and vomiting, chest pain. Vasovagal reaction is not simple, requires treatment, okay? Severe symptoms, life-threatening arrhythmias, cardiac, hypertensive, cardiopulmonary, seizures, syncope, vasovagal reaction that doesn't respond to treatment. Okay? Now we'll come to the last topic, which is the contrast media reaction treatment and management. Please remember these approach considerations. Most acute reactions do occur in the first 30 minutes. Patient, so legal, should be monitored for at least 30 minutes after contrast injection. Remember this point. The radiologists and support staff must be able to recognize, this is what we are learning now, and promptly treat acute adverse reactions regardless of their severity. But anybody who says that this is not my job, he is wrong. You are facing the patient. You are witnessing the allergy. So you have to know what to do. First, diagnose, confirm, and treat up to the limit. Okay? We'll come to when you call emergency. Rooms in which contrast material should be stocked with appropriate basic and advanced life support monitoring. Okay? We'll review it together. The first step in treatment of adverse reactions is to stop the contrast material injection, discontinue the contrast. Monitor the patient for these: cardiac rhythm, blood pressure, oxygen saturation, and pulse. This is mandatory. They will give you the characterization and severity of the reaction. Pulse, if the patient is bradycardia or tachycardia. Bradycardia and hypotension means vasovagal attack. Bradycardia, tachycardia, and hypotension means anaphylaxis. Remember this point, okay? Tachycardia, pulse more than 100, and hypotension, blood pressure less than 60 or 40, this is anaphylaxis. Bradycardia, pulse less than 40 or 50, plus hypotension 60 or below, this is vasovagal attack. This is very important note written in the text to differentiate from the vasovagal attack from the anaphylaxis. The trick is in the pulse. Bradycardia, hypotension plus tachycardia is anaphylaxis. Hypotension plus bradycardia is vasovagal attack. Okay? Mild reactions, self-limiting. Moderate and severe reactions may necessitate support from the local emergency team. Medical care. Medical care in radiology, allergy to contrast, is two groups. Either it is localized for symptoms. We should know how to treat the symptom or sign that the patient know, or to group, is the patient having a mild, moderate, or severe? If the mild, according to the symptoms, ignore. Moderate, you have to observe. It might go into severe at any time. But if the vital signs, we characterize the moderate by controlled vital signs, okay? If the vital signs are controlled, you observe. Also, treatment, as we'll see, it might be just minimal. But if the vital signs are normal, okay, observe. Characteristic of the severity of form of reaction is the abnormal vital signs. Okay? Let's talk about the localized treatment. Mild localized for the urticaria, if it is mild, no treatment. If it is moderate and diffuse, we give them some sort of antihistamine. Diphenhydramine, 50 gram, either in oral or IV or intramuscular. This is regarding the urticaria. The second is the bronchospasm. Mild bronchospasm treatment includes oxygen. So this is one of the basic requirements in radiology modality room. Oxygen is you see that it is a repeated treatment, first line aid in all the cases of allergy. 66 to 10 liter per minute by fast mask, and close observation, beta agonist meter dose inhaler. Oxygen is the most important for mild bronchospasm, might be supported by salbutamol. This is, we'll keep it in our room later on. For moderate and severe cases of reaction of bronchospasm, we'll receive intramuscular injection of epinephrine. Just memorize this drug, because it is the most common drug which is used in cases of allergy and anaphylaxis and severity, severe forms. This is the drug of choice. This is the magic drug. It is intramuscular IM epinephrine. Okay? Just memorize it. You will not use it. That's the job of the technologist, to use it. Just memorize to have it in your stock room. Okay? Laryngeal edema, mild to moderate laryngeal edema, also oxygen. Oxygen is mandatory in this stock room. Also at the same level, and epinephrine by slow infusion. Moderate to severe, consider calling code for intubation. If you diagnose that the patient cannot take any breath, call the emergency room, because there is a different treatment. They might insert a tube, they might give a severe form of epinephrine, or beta adrenergic antagonist. Okay? I want you just to recognize, when you can manage, when you have to call. In laryngeal edema, you have to be specified and cautious. You might immediately call if the patient cannot take breathing, okay? Vasovagal reaction, this is very common. Hypotension with the bradycardia, just elevate the leg. Put the patient flat and elevate the leg. You will enhance the venous return into the heart and improve the circulation and resolve the treatment. Another is oxygen, and if needed, atropine for the bradycardia. This is just for knowledge, as you have to know, but not to practice. But what we can practice is elevation of the leg and giving the oxygen. Okay? Seizures. The most important from our side is to put the patient turned on one side, not to prevent aspiration. Then consider calling for emergency. Any seizure, don't play with it. Put the patient aside, call for emergency. Okay, this is one common physiologic reaction and indicate moderate severity. Pulmonary edema, the ACR suggesting treating this condition with oxygen and laxative and emergency response, of course. This is also the symptoms what we are concerned with. The patient cannot take a breath. He cannot take a breath. Either it is localized problem in the larynx, laryngeal edema, or it is more severe form of congestion in the lung. Two possibilities are present, but this initiates calling, and the previous one, which is edema, if it is moderate to severe, you have to call RRT, okay? Hypotension with tachycardia, this is the anaphylactic shock. Mild to elevate the patient leg, administer oxygen, infusion of fluid and infusion of epinephrine. This is the job of the RRT. Plus you have to diagnose it. Once there is hypotension plus tachycardia, immediately call for the emergency physicians. And of course, if there is unresponsiveness, call a code, basic support, defibrillator present, and admit the patient for monitoring. This is CPR that we are all known what to do primarily in the 5 minutes till the emergency team comes. This is what I want you really to know about the reactions and the severity, and the most important point that as a technician should know when to manage, when to call according to the symptoms or to the severity classification, mild, moderate, severe. And these are the most common symptoms, and thank you very much.